And at this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Thank you. Welcome to CHEO's EHR Journey, an approach to workflow analysis and integration. The Pan-Canadian Change Management Network is pleased to present the fourth in a series of change management webinars. Hi, my name is Barbara McCaffrey from Alberta's Toward Optimized Practice, and I'm hosting today with my fellow Pan-Canadian Change Management Network member, Cindy Hollister from Canada Health Infoway. We will soon be joined by two leaders, Janet Sharpe and Anne-Marie Parent from Children's Hospital of Eastern Ontario, CHEO. During the webinar today, participants will gain insight into how a large healthcare organization EHR journey is being supported by change management activities with focus on their approach to workflow analysis and integration. We will hear how CHEO adapted their vendor approach to workflow analysis and integration by creating their own methodology to better align with their requirements and culture. Finally, Janet and Anne-Marie will share their lessons learned to date and how they continually improve with successive rollouts. In today's webinar, before we get to the presentation by Children's Hospital of Eastern Ontario, we will briefly introduce you to Canada Health Infoway, the Pan-Canadian Change Management Network, and to the National Change Management Framework. To ask a question, please use the Q&A panel at the top of your WebEx screen by clicking on the drop-down arrow, selecting Q&A, and sending your questions to all panelists. The question and answer period will begin after Janet and Anne-Marie have finished their presentations. Now, let's hear from Cindy in Toronto.
Thanks, Barbara, and both a good morning and good afternoon to those joining us from all over the country today. As Barbara said, I'm Cindy Hollister, and I'm a nurse and a clinical leader with Canada Health Infoway's Clinical Adoption Team. Canada Health Infoway, sometimes referred to as Infoway, is a federally funded not-for-profit organization created in 2001 with a mission to foster and accelerate the development and adoption across Canada of electronic health information systems using compatible standards and communication technologies by building on existing initiatives and through collaborative relationships. The Pan-Canadian Change Management Network, supported by Canada Health Infoway's Clinical Adoption Team, is a grassroots collaborative of change leader enthusiasts from across the country, sharing best practices and ideas since November 2009. The network facilitates a national community of practice for change management leaders involved in the implementation of electronic health solutions, providing an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns within the e-health space across the provinces and territories. The change management working groups are formed on an as-needed basis to work on deliverables of the Pan-Canadian Change Management Network and provide national expertise, insights, and input to shape change management strategies and outputs to accelerate adoption and benefits realization of health information and communication technologies and the electronic health record. The Pan-Canadian Change Management Network has developed an integrated framework for describing change management activities within the context of e-health projects that consists of 6 core change management elements. More detailed information for each of these elements can be easily found within our online Pan-Canadian Change Management Network community via Infoway's corporate website, and you'll hear more about this when we cover resources at the end. But the core elements of the framework are made up of governance and leadership, which are the mechanisms used to guide, steer, or regulate the course of a project, including how stakeholders can affect the priorities and progress of a project, as well as the change management activities occurring within a project. Stakeholder engagement is the process by which the perceptions, issues, and expectations of stakeholders are learned and managed. Stakeholder engagement includes focused attention on the individuals who are expected to change. Their behaviors and needs must be defined, understood, and considered when implementing e-health projects. Communications is the process of providing stakeholders with what they need to know in order to prompt appropriate responses and/or actions. Workflow analysis and integration is the process of understanding current work processes and opportunities for improvement so that new processes using e-health solutions can be sustainably embedded into the culture, as evidenced through their presence within steady-state operations. Training and education is the act of imparting both knowledge and specific skills among key stakeholders to promote adoption. And lastly, monitoring and evaluation is the process of reviewing whether change management activities took place as planned and the extent to which they were effective. So having a national change management framework really helps to proactively focus attention on these core and vital activities, aiming to minimize negative consequences. Thoughtful contemplation of these undertakings, both in planning and in execution, proactively considers users of e-health solutions and presents communication opportunities. It also supports the integration of technology into practice and overall supports people and their organizations as they transition from the current state to the newly desired end state. This is the goal of the National Change Management Framework. Our first 3 Pan-Canadian Change Management Network webinars touched on all of the 6 change management elements, but with a primary focus on leadership and governance. With today's webinar, we're turning our attention to the workflow analysis and integration element in particular. So workflow analysis and integration, just to reiterate, is the process of understanding current work processes and opportunities for improvement and allows new processes using e-health solutions to be sustainably embedded into the culture. However, when you're listening to the feature presentation today, you'll also be able to pick out change management activities related to many of the other 5 change management elements. So with that said, I'll turn this back to our moderator to introduce our feature presentation speakers.
Thank you, Cindy. As we get ready to hear from our leaders from Ottawa, I'll be introducing them. Janet Sharpe has 29 years of IS/IT project delivery with a degree in business administration and background as a certified management accountant, project management professional, and as a lean green belt. For the past 6 years, she has been a project manager at CHEO, delivering a variety of clinical and corporate projects. Prior to joining CHEO, Janet was a consulting director, senior consultant, delivering IMIT solutions and management consulting services. She has also worked in provincial government and Crown corporation sectors. Anne-Marie Parent is a business systems analyst with CHEO. Prior to joining CHEO, Anne-Marie was a change management consultant working in a variety of industries, including shared services, IT, and health. Over the years, she realized that she was most passionate about her work in the health sector. She joined CHEO to be able to apply her change management expertise and experience. In addition to her role as a business system analyst, she is also the adoption and readiness lead. Anne-Marie is ProSci certified and is a believer in the power of collaborative transformation. So let's go to Ottawa.
Thank you, Barbara. Anne-Marie and I are thrilled to be here doing the presentation, and we wanted to, oh, there we go. Also, our patient champion, Cameron, welcomes all of you to this webinar. We have been very fortunate, and Cameron and her family have been active, supportive champions around our program communications around the EHR. So just to give you some vital statistics about CHEO, I won't reiterate the numbers that are currently being displayed, but I will highlight CHEO is a pediatric health and academic research center, And we have one of the busiest pediatric emergency rooms in the country, treating over 66,000 patients a year. We also have a very large service area, not only including Ottawa, but also Eastern Ontario, Western Quebec, Nunavut, and parts of Northern Ontario. Annually, we also provide education to 2,300 future pediatricians and students, both in nursing and other healthcare professions. We also offer tertiary care in the region with many specialties. To give you context into CHEO's sort of electronic health record experience, like many hospitals, we implemented ancillary information systems such as RIS, pharmacy, lab systems, health records, and in 2000, we began a relationship with Epic, a vendor of health information systems, implementing a scheduling, admitting, billing integrated system, and that integrated with our ancillary systems of the time. We also, in 2008, implemented an emergency triage system, followed by eClinDoc, which is nursing and health professional documentation for all our inpatient areas, which was quite extensive. And in our ambulatory clinics, we were still paper-based documentation, so we've been very much living in a hybrid chart. And what instigated this was looking at our ambulatory areas and how we were going to document. And out of that, we looked at our entire EHR program, which we are referring to here in our EPIC program. And we developed a plan that we would roll this out in a three-phased approach. Phase one, including our ambulatory outpatient clinics, replacing our laboratory information system and adding in our genetics and pathology labs into the mix. Also a needed upgrade to our ADT scheduling system. It's noted here as Cadence, that's the product name, but it was a scheduling system, and our billing component that was Epic at that time. We have future plans for phase two, which would focus on the inpatient areas, including health information management, our emergency documentation requirements, inpatient documentation, and inpatient pharmacy. And that would be followed by phase three, which would include specialties such as anesthesiology, our surgery and oncology, and undoubtedly an upgrade to the whole integrated EPIC suite. So phase one was also broken down into successive waves as part of our rollout strategy. And wave one was implemented in October 23rd of 2013, and as you can see, it included a number of specialty clinics. And we're right now in the process of wave two, which will be going live April 22nd, and that will be followed by wave three and wave four. And we've provided you with a notation of the clinics that are going to be involved in those rollouts. And the next slide just shows you the timelines. We had a kickoff of the whole program in May 2012, and we completed the initial upgrade to our scheduling and admissions systems, and then got into our build and delivery of our ambulatory wave one clinics and the replacement of the laboratory system with our Beaker system, which happened in October. Right now, we're in the midst of preparing for our go-live in April 22nd, in the midst of doing training delivery. So today, our presentation objectives are really to focus on how we've tailored our vendor EPIC's methodology to come up with an approach that considers our organization's experience and culture. Basically, we initially adopted the vendor's approach, given their experience in delivery and their familiarity with the applications. And over time, we have adapted it to best meet and align with our organizational requirements and culture, and basically developed our own methodology. This presentation will share our story on how we've accomplished this at CHEO and continue to adapt it and improve it with successive implementation rollouts. And at this point, I'll hand it over to my colleague, Anne-Marie.
Thank you, Janet. So at CHEO, we use the standard software implementation process known as the software development lifecycle, which goes through standard phases. So from planning to requirements definition, design, development, testing, user acceptance, deployment or go live, and post-implementation and optimization. I'm referring to this slide as a theory because the reality is that the software development lifecycle looks a bit more like this. And this seems to be even more the reality when you're not developing an application from scratch, but when you're configuring an existing application to meet your requirements. As we discovered, although the process seemed to be a linear one, beginning with understanding the workflows of our clinical users to determining what tools they would need to support that, we often needed to go back and forth and to revisit the 2B workflows and to determine the possible designs that would best meet their requirements. In other words, as we were obtaining information about their as-is workflows and understanding their requirements, we were considering design options, revising the requirements based on the proposed design options, and then redefining the 2B processes. On this slide, we're grossly simplifying the approach that we initially used for requirements gathering process, but basically we first started with the vendor's model system. So this was a system that's developed by the vendor based on standard workflows they have from their other outpatient clinics, client areas using this system. What we also did as our project team is we allocated the resources to document and collect the requirements for all the ambulatory clinics, so waves 1, 2, 3, and 4. The first step involved gathering documentation forms from the clinics to understand the type of documentation they currently use or create, and to determine what the equivalent in the system would be. We also developed a requirement questionnaire, which honestly was more of a pre-meeting questionnaire to help us understand the scope of the clinic, and it wasn't intended to collect all the requirements that they would need for the system. So it gave us a sense of what that clinic needed from the electronic system. As we were collecting this information from the clinic, we were conducting what we call the spotlight validation sessions, where we demonstrated and validated some of the common future workflows that would be applicable to all the clinics. These sessions were primarily led by the vendor because we were still unfamiliar with the system and everything it had to offer. Decisions on these workflows would then impact our core system build. After these validation sessions were complete, we scheduled meetings with each of the clinics to be able to collect more specific requirements in terms of how their clinical builds would be different from the core system. Some of the issues that we identified along the way were that there were some specific advantages and disadvantages to adopting the vendor system. First of all, we knew that Epic was a powerful system. We had worked with our partner for many years, since 2000, and had successfully implemented a multi-year upgrade successfully. However, we were the first Canadian client to implement the EpicCare ambulatory module. This meant that the system was not fully aligned with Canadian legislation or practice standards, and some workflows needed to be adjusted. The model system was also not based on pediatric content. Many of the sample texts or histories and templates were more relevant to adults, and there wasn't much that we could reuse. This created some challenges for us when we were running those validation sessions with our stakeholders, because we were demonstrating workflows that didn't quite align with our Canadian standards, and users had to make some decisions without being able to see what it would actually look like for them. We also had significant time constraints in trying to gather requirements for all waves at once. Basically, we were a team of 8 members collecting requirements for 40 clinics. This led to limited weekly progress on each clinic. At the same time, as we were working with all the clinics, we were starting to get a better understanding of the similarities and differences across all our ambulatory clinics. Another issue that limited our ability to collect the requirements effectively was that our physician, nurse, and health professional SMEs were not trained in the application. So it was challenging for them to provide the type of requirements we needed to translate into an appropriate design. They could also not comment on whether the proposed design we were showing to them without understanding what the alternative design options were. So we were often asked to go back and inquire about how other pediatric institutions had managed this. Because we didn't fully appreciate all the build components that were required to make the system work for a specialty, we hadn't developed a standard documentation to capture the information. Given that our team included a mix of individuals with clinical or technical background, we would naturally collect requirements differently. But both types of individuals still brought an interesting perspective to the requirements approach. And without a standard document to document those requirements, it was very difficult for us to be able to provide a status on where we were at, or even to be able to identify an appropriate scope on what was truly required to go live. As we were collecting the requirements for all waves, we really only needed to be ready for wave 1. But as we were thinking about workflows, we needed to consider how these new workflows for the wave 1 clinics would impact the other clinics that weren't going live until later. Even if this project was primarily focused on ambulatory clinics, it had an impact on our inpatient and emergency departments, and also on all of our ancillary services, including diagnostic imaging, pharmacy, and health records. And we were also implementing the lab system at the same time. There were also significant impacts on existing interfaces which we needed to adjust to accommodate the new clinics going live, but also not change the existing interface for those clinics that weren't going live onto the system. So when we reached the time where it was needed to build the applications for these specialties, the project team realizes that we needed to revisit our approach to ensure that we address some of the issues and risks that we identified. So to address this, what we did is we first started by visiting another pediatric site in the U.S., and we gathered some of their lessons learned from implementing the EPIC ambulatory system. We also restructured our project team, so we had some members of our team focused on client consultation and other members more focused on the technical and design aspect of the system. We also refocused most of our tasks on wave 1. We redefined and improved our requirements template and trackers, and we also accelerated our training for our physician leads and subject matter experts so that they would have a better understanding of the system and what it looked like. We also increased our attention on the integrated scenarios, so understanding better for the clinics going live and the scenarios with the other areas they would interface with in the hospital. So overall, our requirements gathering approach changed. So at this time, we had a much better appreciation of the application and the needs of our clinical users and which parts were more relevant to ensure user adoption. And as a side note, it really didn't matter if we were building the greatest system if no one ended up using it. So with this in mind, we changed our requirements gathering approach from focusing on build components to focusing on more functional components. And as we learn and are continuing to learn, the focus really changed by starting with the workflows and mostly from a patient care point of view. And then for each type of patient population being addressed by a specialty, we would then identify what workflows were relevant, what documentation they would need to do, what type of ordering they would need to place, and any other tools relevant to be able to care for those patients. Our requirements gathering tool were adapted to collect requirements under these categories. So starting with workflow and business rules, and when we identified this, we also identified some needs to change existing policies or to create medical directives. We also identified the types of users and security they would need, the type of ordering and rules attached to that, ways for clinicians to be able to review the patient's history, to be able to document on the patient, getting the information in, reporting out from the system, so getting the information they've inputted it out in a meaningful way. Also looking at the physical layout, so this included hardware review and renovations in the clinical areas to accommodate for the new equipment coming in, and also the whole billing implications of going on an electronic system. So we reviewed our design process, and we started by sharing with our physician leads and SMEs tools to help them understand how we would work together. We also tried to break down our design sessions into 3. The first one focusing on workflows and users, the second one focusing on ordering and reviewing, and the last one focusing on documentation and charting. We also took time to differentiate the requirements gathering process, focusing on what they needed, with the design process, which focused on how we would be able to meet that need. After this, we would build the system and then go through a testing and sign-off phase. This diagram reflects a bit of the story we try to share with our physician leads and SMEs, so starting from creating the system that they need, to giving them a chance to be able to preview the system, to them learning how to use the system effectively, and actually supporting them through their use of the system. So these next few slides will drift a bit from the concept of workflow analysis and integration, but these were important realizations that we've made that really had an impact on making a requirements gathering process effective. So here are some of the points that we learned around helping our clinicians go through the paradigm shift of what it meant to document on paper and going through an electronic system. So once this shift was made, the nature of our conversation changed and the level of engagement of our SMEs really increased. So the first lesson that we learned here was to make it relevant. So during those initial validation sessions, we were presenting context and workflow that was more adult focused, which wasn't appropriate for our audience. We also realized that it would have been worthwhile to create some of those relevant scenarios so that the users could see themselves in the scenarios being presented. We also needed to be able to provide some tools to translate the new terms and concepts they were being exposed to. So developing a crosswalk of what is documented today and how that would be documented in the EHR. There was also some new concepts we needed to describe, like what an electronic encounter was versus a patient visit, and information about the patient's history. As we were working through the information sharing scenarios with the team, we were able to focus on problem lists and the patient history and gathering information like that. We also recognized the new challenges that they would face. So there was a significant learning curve that needed to be recognized, and we needed users to know that it was okay if they didn't understand everything up front and that their knowledge and skills about the new system would evolve over time. We also discovered that it was best not to oversimplify the system or the changes and to allow users to understand its complexity. This encouraged them to better understand the system and over time to be better able to express their requirements or future design suggestions. We also spent some time on highlighting the benefits. So we recognized that there was a slow learning curve to be able to use the system, but over time they would really benefit from the ability to extract and analyze the data that was put into the system, either from a clinical or research point of view. This next slide really shows the 2 activities that were most effective in helping us with validating our workflow and design suggestions and also increasing adoption. The first one was called the workflow walkthrough. So basically this was a demonstration by the project team of the proof of concept that we built for them and to obtain a validation by the whole team, so the whole specialty area. These sessions were specific by specialty, and they were also, in some cases, multidisciplinary. These could have been scheduled before or during training that the end users were scheduled for. In contrast, the direct rehearsals were where we provided clinicians with paper-based workflow, and they were using the system, so they were using kind of a test system to be able to go through these mock scenarios in their clinical area. So this would provide them with a sense of how we would feel on the first day when they were going live. These sessions were typically scheduled after the users received their training so that they could get a sense of whether or not they needed to go into our practice lab and try to learn the system a bit better before the actual go-live date. So in summary, these last two slides will show you some of the major lessons learned that we discovered through this project. The first one was about setting a reasonable scope. So defining what is good enough. So initially, we had a scope suggested by the vendor, which was basically to provide a few of every feature to allow the clinicians to document on the majority of their patient population. While we recognize the best practices and experience that the vendor brought to the table, we had to refine the scope to obtain buy-in from our clinicians. So we identified our scope as the ability to document on 80% of the patient scenarios and to gather feedback after go-live to be able to address the remaining 20%. So even if we were kind of limiting the scope to being able to document electronically on 80% of the patients, it didn't mean that 100% of the tools needed to be there at go-live. One thing to note is that our clinicians in our environment were still permitted to dictate their notes and to provide them with more time to become more efficient with using with the system. So we had a few templates that they could use to chart into the system, and we knew that we would add some or refine those as they became more familiar with the system. We also recognized that this was not a linear process and that it could be iterative. So we needed to allow some time to be able to go back and forth on the requirements and the design as our users had a better understanding of the system and what it could offer. Next, it was very important for us to define an approach that was tailored to our organization. So our vendor came with an approach that was developed and based on their lessons learned and best practices. But as we learned and understood their approach, we realized that we needed to adapt it so that it would consider our organizational culture and our experience with previous projects. We also discovered it was important to allow the team to understand the current business, so either through in-clinic observation of how that clinic worked and the types of patient populations they were working with, and also allowing for time to discuss the commonalities and differences between the different specialty areas. We also learned that it was very important to train the subject matter experts. This immediately increased their adoption and engagement with the project. It also led to better requirements gathering, and it also led to them giving us some better design options for how the system could better meet their needs. And it also reduced the need for educating during those meetings where we're trying to collect requirements. Lastly, and to be able to have kind of a limit on the requirements we were collecting before go live, we needed to be able to formally plan an optimization phase. So this allowed us to say, do we have enough tools to go live? And then after go live, we'll come back, and while you have more experience with the system, be able to optimize based on your lessons learned and what you've identified is missing. And this pretty much sums up what we learned as we went through the first wave of this project.
Wonderful. Thank you, Anne-Marie. Janet, do you have anything to add at this time?
No, I just wanted to hand it over to you, Barbara. Thank you.
Okay, thanks, Janet. I want to remind participants that are across the country that you can submit your questions. Just click the drop-down arrow and select Q&A if you don't see it on your screen, and we'll be directing the questions to Anne-Marie and Janet. The first question is about during the dress rehearsals. So you mentioned design by common scenarios when you discussed helping clinicians make the paradigm shift from paper to electronic. Can you provide more details about how you developed and used the common scenarios? For example, did you develop them from simple to more complex?
Yes, and I can answer that question. So when we shifted to focusing more on some of the workflows, it wasn't necessarily going from simple to complex, but it started with some common workflows. So what's the process when you're going through a new consult? So a patient that has never seen before at the hospital and a referral that you're trying to address. We then looked at some different scenarios around follow-up, so a patient that had already came to the hospital and visit and how a follow-up visit was different. And in some cases, those workflows might be different based on the specialty and the patient populations that they were seeing. There were also some different workflows we were looking at, including like telephone encounters, or other scenarios where maybe no physicians were involved, but it was mostly a nurse or a health professional that was included into that workflow. So it wasn't necessarily from simple to complex, but more getting an understanding of the clinics and the type of work that they did.
Thanks, Anne-Marie. The next question is, in clinics that have already gone live and as part of the current clinic's implementations, how are you ensuring that there is no redundant clinical documentation as they move forward?
We've used probably two strategies so far. We have been doing PostGoLive Checkins with our currently live Wave 1 clinics, and that's an opportunity to review what's gone well, any issues, to prioritize the optimization activities. But it's also a time to get the interdisciplinary team around a table along with the project team and highlight any issues potentially about finding documentation or documentation practices. The other portion is we are doing sort of strategic audits on key documents where there may be some question as to, is it documented consistently in this one type of document area or another, and we've used that strategy on not only this project but on our previous eClinDoc project.
Thanks, Janet. The next question is a human resources related question. How did you plan to engage and motivate stakeholders, especially physicians?
Well, we've had sort of a multi-prong approach. Our physician champion has developed a physician engagement and support sort of team that in early stages the focus was more education and communication, doing demos to physicians, identification of physician leads who were our subject matter experts for each of the clinics, and then subsequently following up with the approach that the team took in terms of the validation sessions and the dress rehearsals, and as well identifying sort of post-go-live any additional support training. We've done shorter targeted training sessions on particular topics that have been of interest to physicians as well as our health professionals. We've had a very active approach in terms of identifying our subject matter experts and engaging them in the process up front as part of the definition of requirements and working through the validation workflows, et cetera. And one of the lessons learned from Wave 1 was getting them access to the system to see how it actually works and flows. And we were able, as part of Wave 2, to schedule our subject matter experts into sort of a 4-hour orientation to the application and be able to sit in on a typical training approach for their given role. And that really gave them background on how the system could work, and they were selected as subject matter experts because they knew their own clinics and their existing documentation and workflow. So once you had those two components married up, it brought much more effective requirements gathering and dialogue between the team and the subject matter experts. As well, we also identified early in the process the need for super users. Some individuals transition from being subject matter experts into super users, but as well we recognized that a super user also had a specific skill set that we were looking for in being champions and as well being comfortable with technology. And we engaged them early in the process to get them trained in the application so that they could be supports during the training sessions of end users, assisting the trainers, and as well building up that knowledge base so that they could then be placed back into their respective clinical areas and provide at the elbow support.
Thanks, Janet. I think you're really speaking to many of the other elements of the change management framework.
Yeah.
The next question is about benefits. So what are some of the benefits that were measured, realizing that you are early in the project, but can you provide a brief overview of how this was done and what time of the implementation it was performed?
Well, I'll jump in and then Anne-Marie can also speak to this as well. We've done readiness assessment measures up front prior to go live through surveying of end users before and then after. As well, as part of our implementation program, we've identified some key performance indicators. And as part of that, where we could, did pre-implementation measures so that we could kind of baseline where were we before go live, and then as part of the implementation, generating regular reports afterwards to track those key indicators. Some of them include encounter close time, so how long does a patient's electronic chart remain open after a visit before it's formally closed off, and that has billing implications, et cetera. We're also looking at appointment turnaround times as well, and we have a couple of other measures that we're following. We are looking at doing sort of a formal benefits evaluation post wave 4 as well, but as each wave is deployed, we are doing individual measures of each clinic before and then afterwards as well.
One of the surprises of this implementation has been, I think, our metric around the number of open and closed encounters and how quickly encounters were being closed after they were open. Something else to note is with the system, the vendor also proposes some key metrics. So we adopted some of those suggestions. And one of the surprises, as I mentioned, was that a few months after go live, 85% of our encounters were being closed within 5 days. And that was dramatically improved from what it was before. And by closed encounter, that meant that all the documentation was done in the system and that the billing was included in the system and potentially the letter back to the referring provider. And even when the statistic was shared, I think people were quite pleased with that result. And I think one of the key impacts of that is in the system tells you how many open encounters you have open, and none of the clinicians like to see a number in there. So every Friday or before the weekend, they would ensure that all their encounters are closed. So it created some new behaviors with very minimal effort on our part.
Thanks, Anne-Marie. That's interesting, especially that you can speak to that consult letter going back to the provider. That's a great metric. The next question is about the project team. How many members are on the project team, and can you speak to their roles?
Well, we had several team components, but we'll just speak to the ambulatory team. I think including both the application analyst role and our technical team, as well as the training team, we're probably around 30-ish involved in the project. That doesn't include our vendor partner, who has sort of corresponding roles that help support our direct team members. And then as well, we're supported from the organizational management and clinical teams. We have an operations task force that has representation from our managers and directors that are impacted either in wave 1 or any of the waves. And that's a major sort of linkage on the change management in terms of ensuring clinical readiness. We, discuss the tasks at hand that are going to impact their clinical folks, whether they're subject matter experts, super users, or just the end user training population, and the rollout and post-implementation activities associated with that. And as well, our various stakeholder bodies that are part of our project governance. And I mentioned as well, we had a physician engagement role as well.
Did you conduct a gap analysis prior to implementation? And how did you plan for the future state assumptions For example, you assume that the organization does reach an MRAM level, stage 6 or so?
Actually, that was part of our 5-year strategic plan in terms of where we were in a HIMSS level and sort of the larger strategy for the next 5 years, of which this 3-phase program folds into that. And the whole evaluation of going with an integrated solution was part of, we did a review of our existing applications, what the gap areas were, and compared that to what the integrated solution would offer us.
Thanks, Janet. What was the time frame that was used to complete the workflow analysis process?
Yeah, that probably is a difficult question to answer. So I think initially with our wave 1, because we were learning a lot about the system and what could be done, so probably for our first wave, some clinicians were engaged for a 9-month period, which seems quite long to work at the workflow, but our team was trying to understand the system. I would tell you that moving forward, that duration would be reduced to probably something more around like 2 to 3 months instead of 9 months to really go through some of the workflows. And maybe to come back to that is we start by kind of high level understanding the workflows, and then as we dig into those, try to understand the tools or the things that we need into the system. So there's kind of an initial assessment, and we dig deeper, and then we kind of come back at the end and do a review of those workflows. So I'm kind of sharing that whole process could cover over 3 months.
Anne-Marie, in addition, you spoke a lot about clinical documentation. So in addition to clinical documentation, were there any other functions deployed, such as order entry, prescription writer, MedRec?
Yeah, so this was completely electronic. So things that get documented in the system are patient vitals when they arrive, reviewing the patient's past medical history, past surgical history, family history, and those are all templates that we could customize to make it faster for the clinicians to document. Things like allergies or current medications they're taking, and the whole order entry process was a significant part of our work in the first round because we needed to integrate with diagnostic imaging. We were also building the lab system in parallel, so there were some challenges there in terms of collecting the lab requirements before that system had been built and reviewing some of the processes there. And then also just the kind of internal referral process, so from physicians referring to another physician in another specialty, so that was all included into the process. And lastly, also a way to kind of include patient instructions and follow-up information to know when the physician or clinician would like to see the patient next.
Thank you. Next question is about when are you planning to go live with your inpatient and emergency?
We're looking at that, starting that project up closer to the end of wave 4. So we'll be looking at that in 2015.
Thanks, Janet. Regarding developing standards for requirements gathering, did the vendor provide the document template?
So the vendor did provide some documentation templates. What we found is the documentation templates were more on a tool-by-tool basis. So they were more like around, okay, what are the history templates you need? What are the smart texts? So those would be the template notes that you need. What are the common orders that you need? So there was a template to collect it in that way. We just didn't find that template really helped to solicit the requirements in a way that was meaningful for the clinician. They were a useful way for us to be able to document what needed to be built into the system, but not to document the actual requirement of, in the end, what do the clinicians need to be able to do and use in the system to care for their patients.
Anne-Marie, we know that leadership and governance is a really important element in the change management framework. So the next question is about sponsor engagement. So what was your sponsor engagement strategy? Did you need any sponsor, or did you do any sponsor coaching?
We didn't do sponsor coaching per se, but we were fortunate in that we were able to leverage our leaders' experience in a previous large-scale implementation, which was on the inpatient side. So as part of that, we already had an EHR steering committee that existed, and that was just reviewed in the context of the rollout with, well, the successive waves. So it wasn't strictly focused on outpatient. It would include the inpatient perspectives as well as the ancillary representation. And as well, sort of the weekly engagement of the directors in the respective areas through our operations task force. So there, we would meet with them on a regular basis to review, progress, any sort of flags that were developed in terms of readiness that could be addressed if they hadn't already been addressed specifically within the clinical setting. And as well, we have our executive IS steering committee that sort of our chain of governance structure. We have the project team, we have the operations task force, then the EHR steering committee, and our executive if need be in terms of executive direction.
And maybe just to add on a bit, Janet, one of the things with that operation task force, so that's a group that included kind of the managers that were closest to some of our end users. When it came to supporting their work, so the project team tried to not own every stakeholder engagement or user sessions, and we tried to engage some of those managers into that, and in some cases would provide templates or sample communications that they could use to be able to do their work. And parallel on that side, with the physician group as well, there was some mechanisms or tools to help with the department chiefs to help us through the process. So not necessarily at the sponsor level, but maybe a bit closer to the people that were directly engaging with our end users.
Thanks. Thinking about workflow analysis and integration, so did you integrate into any of the other provincial services, such as OLIS or Panorama?
We actually had looked at integrating with EHR. In fact, we do have a link from our ambulatory system so that clinicians can log into EHR, which is the electronic children's health network, where clinicians can share results of pediatric patients. And we have also tested sending some documents to a regional document repository. We are looking longer term into the integration with OLIS. The first step is actually for our lab system to, as part of our sort of regional lab, ERLA, to share the results into OLIS, and then as well, perhaps down the road, looking at access from the ambulatory application into OLIS. But I think the first step will be sharing our lab results to OLIS first through ERLA.
Thanks, Janet. There's a number of questions about the vendor, and we have 5 minutes left, so I think this might be our final area. But first of all, how did your relationship with your vendor change over time as this project progressed?
So initially, the vendor was very much leading the process. So they were familiar with the system, they had experience implementing it in other organizations, and they came with their methodologies and their plans and led us through that process. But over time, we quickly realized that some parts of their approaches suggested needed to be tailored, as we demonstrated in this presentation. So we began taking a bit more the lead on the approach, on some of the documentations or tools we needed to go about the project. And I would say right now the vendor is more in that expert advisory capacity because they have an understanding of the system. So when we have these new scenarios or maybe more complex requirements with some of the new clinics coming up, they're there to support us in identifying just some better design solutions. So they help us link to the rest of their client base and getting us some information of, what are some different ways we have to connect to do a certain design for our clinics.
And since the vendor was based in the U.S. and initially you were the first to implement the system in Canada, what do you find most challenging about this?
I think there were some things just around their terms. There are some differences, especially in the United States. There's concepts like meaningful use that we do not have in Canada, so those are like specific requirements that all hospitals must meet, and it also makes it easier to implement electronic health record system when you kind of have those standards that need to be met. Also, there were some challenges, just differences around the billing aspect of the system and the mentality around that, and things around whenever orders are placed in the States, they're always associated with a diagnosis. So the system offered some of that, or it was a requirement, and we needed to ask if there was a way for physicians to place orders without directly linking it to some diagnoses. So there was just some little shifts and I suppose their mentality or when they were presenting that were just not as relevant to us.
Thanks, Anne-Marie. As we're coming to the close, first of all, I do want to remind the participants that there is more information on workflow analysis and integration as well as other elements of the change management framework, and they can be found on the change management resources on the Infoway website. We also invite participants that are participating today to join us on LinkedIn in the Pan-Canadian Change Management Network. And as we conclude, I very sincerely want to thank Janet Sharpe and Anne-Marie Parent for sharing their approach at Children's Hospital of Eastern Ontario with their implementation of their EPIC system, as well as their lessons learned. Before we sign off, Janet or Anne-Marie, do you want to say any final words?
No, just thank you for the opportunity to share our experience with you.
Same here.
Well, it's been our pleasure. I want to thank the attendees on the line. I also want to remind everybody that is participating that there will be an evaluation that will follow within a week, and it will include links to a PDF version of this presentation that will be available for download, as well as a recording of the webinar that can be shared and enjoyed at a later time. So in final words, thank you to everybody on the line, and thanks to our team in Toronto.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.